I made this model of a clubfoot to demonstrate the proper manipulation to correct the deformity. Counter pressure is applied with the thumb over the lateral aspect of the talus, while the mid and forefoot in supination are gradually abducted. As the calcaneus abducts, it everts and slides laterally to its normal position under the talus. The clubfoot cannot be corrected when counter pressure is applied to the calcaneocuboid area because it prevents the calcaneus from abducting, in turn blocking the abduction of the whole midfoot. Complete correction of the clubfoot requires severe abduction of the midfoot and forefoot to stretch the tight medial tarsal ligaments. From the back we see that without touching the heel, when the foot and calcaneus are abducted, the heel everts into valgus, owing to the curvature profiles of the subtalar joint surfaces. A 3-day-old baby with bilateral congenital club feet. The feet are in severe supination and adduction. The heels are inverus and equinus. There is some cavus. The cavus is corrected by supinating the forefoot. The foot adduction is corrected by abducting the forefoot in supination, while counter pressure is applied over the lateral aspect of the head of the talus. A thin cotton bandage is applied, tightly over the foot and lightly over the calf. The correction is maintained while the cotton is applied. A plaster bandage is applied over my fingers to prevent crowding the baby's toes. The plaster is well molded. My thumb changes position often to prevent pressure sores over the head of the talus. The heel is well molded. The cast is extended to the upper thigh. A similar plaster cast is applied to the right foot. The first cast maintained the feet in supination and equinus. 5 days later, the casts are removed. The feet are manipulated again. New plaster casts are applied. The forefoot in supination is abducted to the neutral position. The correction is maintained while the cotton is applied. The foot and heel are well molded. The plaster cast is extended to the thigh. The plaster cast is applied to the right foot. The foot and heel are well molded. My thumb over the lateral aspect of the head of the talus changes position often. The completed second plaster cast maintains the feet in equinus, in supination, and in minimal adduction. The plaster over the toes is trimmed off. The heel varus is improved. 7 days later, the second casts are removed. The feet are manipulated again. The forefoot is abduction in some supination, while counter pressure is applied with the thumb over the head of the talus. A new plaster cast is applied to the left foot. The heel and malleoli are well molded. The sole of the foot is well molded. The foot is abducted. The plaster cast is applied to the right foot. The foot is abducted without externally rotating the leg. The third plaster cast maintains the feet in equinus, in some supination and some abduction. When the third casts are removed, the feet are manipulated again. The forefoot is abducted in minimal supination. In the completed fourth cast, the feet are in about 30 degrees of abduction, in minimal supination, and in about 20 degrees of equinus. 7 days later, the fourth casts are removed. All the components of the clubfoot deformity are corrected except for the equinus. The heel cords are tight. Under a skin anesthesia, the heel cords are severed subcutaneously to correct the equinus. New plaster casts are applied, holding the feet in 70 degrees of abduction and 15 degrees of dorsiflexion. The feet must never be pronated, nor the heels pushed into valgus. Three weeks later, the fifth cast are removed. The feet are well corrected. A foot abduction orthosis is worn for 3 months. At 4 months of age, the feet are fully corrected and pliable. Graham started to walk at 10 months of age. Now, at 1 year of age, he walks well. He stands on his toes. His feet look and are functionally normal. To prevent a relapse, he wears the abduction bar at night. A 2.5-month-old baby with severe club feet. After 5 plaster cast changes, the parents were told that the baby would need surgery. The baby's feet are in severe equinus, abduction, supination, and the heels are in varus. There is a deep crease on the inner aspect of the foot. The ligaments and tendons are very tight, allowing for little correction at the first manipulation. The foot is abducted in supination while a finger is applied over the head of the talus. A 2-inch wide roll of plaster bandage is applied over a thin layer of cotton. The plaster is molded at every turn following the contours of the foot. The forefoot is abducted in supination, while the thumb applies counter pressure over the lateral aspect of the head of the talus. The thumb moves often to smooth the plaster over the talar head. The plaster is now extended to the upper thigh. The left foot is stiff and resists correction. The medial skin crease is deep. The forefoot is abducted in supination while a roll of cotton is applied tightly over the foot and loosely over the calf. Observe that I am holding the foot in supination and abduction with my left hand, while my right thumb is over the head of the talus, thereby improving the cavus and reducing foot abduction. The heel is not touched. A plaster bandage is applied over my fingers, holding the baby's toes to prevent crowding them. The foot and heel are carefully molded while rolling the plaster bandage. My thumb keeps moving to smooth the plaster over the head of the talus to prevent the pressure sore. In the finished plaster cast, observe that the feet are supinated. The plaster over the toes is trimmed off. Five days later, after the casts are removed, the baby rests on the mother's lap while the feet are manipulated. The cavus is improved when the forefoot is abducted in supination, while counter pressure is applied over the head of the talus. Same corrective maneuver is done on the right foot. The medial crease is deep. Pressure is never exerted on the heel. The manipulations are gentle. The baby does not cry. Now the baby is placed on the table. The plaster cast is applied while I'm holding the foot in supination and abduction. The heel is well molded. The medial malleolus is molded. The cast is extended above the knee. The plaster cast is applied on the right foot. The plaster cast is smoothed over the head of the talus. In the finished second plaster cast, the feet are still in severe supination, needed to continue the correction of the cavus. When the casts are removed, the feet are improved. The feet are manipulated again. The forefoot is abducted in some supination, while counter pressure is applied over the head of the talus. The third plaster cast is applied, while the foot is abducted with the forefoot in some supination. The heel and malleoli are well molded. The baby goes to sleep while the plaster sets. The feet are still in some supination. Five days later, after the third cast are removed, the feet are quite improved. Again, the feet are abducted against the thumb over the head of the talus. Externally rotated. A bottle of milk relaxes the baby. After the fourth cast are removed, the feet are noticeably improved. The cavus is now corrected. The feet are manipulated and new plaster cast applied in 50 degrees of abduction and attempting to correct the equinus. The feet are never pronated. The heels are never pushed into valgus. The casts are well molded. After the fifth casts are removed, 5 days later, the feet are corrected except for the Aquinas. The tendo Achilles is tight. After a skin anesthesia embedded in prep, the tendo Achilles is percutaneously sectioned in both feet. The last plaster casts are applied holding the feet in 70 degrees of abduction and 15 degrees of ankle dorsiflexion. The arches of the feet are correctly molded. I'm checking blood circulation in the toes. The baby was not bothered by this minor surgery. After 3 weeks in Iowa City, baby and mother returned home to Idaho. 3 weeks later, the casts are removed by their doctor. There are no scars on the corrected feet. A foot abduction orthosis is worn for 3 months. At 6.5 months of age, the baby's feet look normal. The feet are limber. At 13 months of age, Isabella started to walk. Now at 14 months, she walks well. Her feet appear and are functionally normal. To prevent a relapse, she wears the abduction bar at night. Rosa Snyder's Clubfoot, which I treated in 1956, represent the longest recorded follow-up treatment of the deformity. Now in his 40s, Ross has painless, normal-looking, and functional feet. He's a pharmacist and stands most of the day. He regularly jogs and even participates in marathons.